Thank you very much for having me. It's early in the morning here in Belgium, so I would like to talk about the tips and the tricks in an interlaminar full endoscopic discectomy, and especially what to do in an axillary disc herniation. The discussion will be started by showing you a case, Eric, who has an L5-S1 axillary disc herniation, and the learning objectives of this talk are to recognize that the disc herniation in the axilla changes the surgical steps when you do your interlaminar surgery, and to be able to explain why the flavum opening is started very medially, and also explain how crushing of the nerve can be avoided when doing that kind of surgery. So first of all, our case, it's a male, Eric, who's 30 years old, had no previous spine surgery, has sciatica in the left leg for 2 months, with a straight leg raising test positive at 30 degrees, and it progressed to an S1 paresis. The EMG test also shows S1 nerve problems. So the first exam performed that was shown to me is this CT scan. When we closely look to the upper left image, we see that there's a down migrated L5-S1 disc fragment with also 1B disc fragment at the lateral recess. If we look here on the slice, we see the disc fragment, but very important is that you compare left and right side to see where the S1 nerve actually passes in that area, and on the normal side you can clearly expect the S1 nerve to be over there. On the contralateral side, especially on CT scan, it's not so clear which is which, so which is the nerve and which is the disc herniation, but I would expect the nerve to be over here, and this is then the disc fragment. So actually on this image I could already expect that the disc fragment is not lateral of the transversing nerve, is actually in the axilla. And when you do endoscopy interlaminarly, it's quite important that you realize and do a good preparation before you start your surgery, so you can adopt your surgical technique to have a safe and clear surgery. The patient, as already mentioned, developed an S1 paresis, so an additional MRI was performed in my hospital. Again, we see a similar image. Contralateral side, you clearly see the S1 nerve, but on the opposite side there's disc material where you see that the nerve is pushed against the wall of the lateral recess, and the disc fragment is actually median of the nerve. So this changes my way of thinking of performing this surgery. Here on these images you can clearly see that it's a down migrated fragment. Since anatomy of S1 nerve, also higher levels, but if there's a down migrated fragment, there's a bigger chance that it will be in the axilla of the transversing nerve. I always take an X-ray when I plan to do an interlaminar approach. Here you see that the patient has a big interlaminar window and big means it's broad and it's high. So that actually means that the surgery will be able to be performed very minimal invasively, without resection of any bone, without any laminotomy, just by opening the flavum. So what is the plan for this patient? To do actually an interlaminar approach at L5-S1 and avoid bony decompression for access if possible, and to visualize and decompress the axilla first, and then do the usual full endoscopic steps. So I show my plan. I open the flavum ligament as medial as possible. So actually just opposite to the spinous process, and I progressively cut towards the lateral recess. So this is lateral, this is medial, the head of the patient, feet of the patient. I already opened the flavum. You see the epidural fat, and I'm progressively cutting with my scissors towards lateral. This is already a lateral recess. I then use a more curved scissors to be able to cut even more towards the facet joint, and open the flavum completely towards the margin, the medial margin of the ascending facets. So medial starting. When you do not have that plan and started opening your flavum more laterally, which is possible, and then go towards the lateral recess, what could be the problem if you did it that way? Well, then if you see that you cannot see the axilla, but you actually only see the transversing nerve and lateral of the transversing nerve, you will have to be obliged to reach to the fragments. You will be obliged to open flavum again towards medial, towards the midline. For this, you can use the kerosene punch, or you can also again use the scissors, but you have a higher risk for dural tear when you start that step in a later phase of the surgery, especially when here where the green circle is, the flavum ligament is already opened. There's a hole, and there's a hole towards the dura, towards the spinal canal. When you use the punch and you use it to grasp towards the midline, you can blindly grasp folded dura over here. When you use the scissors and you push on the scissors, they can easily fall towards the area of least resistance, and they fall inside the spinal canal, and then the sharp tip of your scissors or even the blunt instrument could damage the dura. So when you opened the flavum from very medial, as we already did, you should then, when you expect an axillary disc herniation, look for the axilla. When you compare this image to this image, you actually see from anatomy that the nerve is curved and is pushed towards lateral. Normally, you would expect it to be more straight. You dissect the axilla area, you identify the lateral margin of the transversing nerve, and first steps will be to remove the disc fragments which are inside the axilla of the nerve. So here you see me using the rongeur and gently debulking the area which compresses and actually also immobilizes the S1 nerve. So what you normally would do when you do a classic full endoscopic surgery is to try to mobilize the nerve towards medial. But if you do that, you actually crush the nerve between the instrument which pushes the nerve towards medial and the disc fragment which is medial, and you will crush the nerve in between those two. So first clean up the axilla and then continue the surgery. Also very important is that you do not put your cannula or your endoscope inside the spinal canal and certainly not inside the axilla. So on this image, you can clearly see that I'm still hovering, floating with my cannula at the flavum. You see the borders of the flavum. You continuously see those borders, which means that my cannula and my endoscope are still outside the spinal canal. And the only instrument which went inside the axilla to gently remove the fragments was a 3mm rongeur. This makes it very subtle and very safe to perform the decompression of the axilla. The next steps in the surgery, when you have an empty axilla of the S1 nerve, are the classic steps. So you go with your nerve dissector to the lateral recess, you mobilize the nerve towards the midline, you put your cannula deeper towards the floor of the spinal canal, you turn it 180 degrees to protect the nerve, and then you can look for residual disc fragments, look for the annular tear, and maybe do an intradiscal debridement of loose fragments if necessary. So the endpoint of the surgery should be pulsating dura and S1 nerve with a clearly decompressed axilla, lateral recess, and at that moment you can know for sure that you have helped, that you have treated your patients. So what was the take-home message of my speech? That you have to recognize before you start your surgery that there's a disc fragment in the axilla, because it changes the way you will start your surgery. The very first step of your surgery is different. You start very medial when you open your flavum, and you do not push your cannula or your endoscope into the spinal canal, and certainly not in the axilla. You remove the axillary disc herniation first, and then you can proceed with the surgery that you're used to perform for a simple disc herniation. I thank you for your attention.
Dr. Peter Van Deel, an excellent presentation, a very, very step-by-step demonstration of what to do and what not to do. I think this carries a beautiful message to all the young people in the world of endoscopy, that certain rules, certain steps need to be honored if you want to have good outcomes. I once again thank you for your precious time. You have adjusted yourself a lot for your participation, sir. Thank you so much. Thank you so much from India. Welcome.
Thank you.
I will